Thank you for joining our webinar today. We are going to give it just another moment as attendees enter into this session from our waiting room. All right, I think we have just about everyone brought in from the waiting room. So first of all, my name is Jessica Elliott. I am a Quality Improvement and Practice Transformation Advisor here at the Regional Extension Center. Today's topic is going to be on the Physician Fee Schedule and Quality Payment Program Final Rule. This rule recently dropped, and so we want to take a few moments with you to go over some of the highlights and some of the important need to know points of information from this rule. So before we get started, just our disclaimer, the information contained in this presentation is for general information purposes only and does not attempt to provide medical, mental health, or any other type of healthcare service. This presentation is not intended to be an alternative to medical treatment, and the content of this webinar may not apply directly to specific circumstances. The information is provided by UK Healthcare's Kentucky Regional Extension Center. And while we endeavor to keep the information up to date and correct, we make no representations or warranties of any kind, express or implied, about the completeness, accuracy, reliability, or suitability with respect to content. Now, today I am also joined by my fellow quality improvement advisors, Robin Kernel and Jared Deason, as we take you through a walk of the finalized changes for 2025. We do have some retroactive changes that impact this current performance year, 2024. So we will make sure to highlight those as we go through the presentation. We are going to talk with you about some of those changes to traditional MIPS. As well as MVPs, including the four performance categories, any adjustments to those. We'll also talk about the APM track and bring out some highlights from the Medicare Shared Savings Program, any changes to that program. We also, while we do primarily focus on the Quality Payment Program section of this final rule, we will try to do some high-level highlights from some of the other physician fee schedule regulations that have been enacted for 2025. So in case you are interested in a specific citation for this regulation, the full title is listed above. I won't read it off to you, but you can see that it does cover several different programmatic areas within CMS. As well as those are the CFR are those codes of federal regulation and the parts that are impacted by this particular rule. We also have some fact sheets that are linked as well in this presentation. If you would like to get a little bit more in-depth information and read through some of those fact sheets yourself, please feel free to utilize those resources as well. Want to talk to you a little bit about traditional MIPS and MIPS Value Pathways to get us started. Most of you are probably familiar with the different tracks of the Quality Payment Program. We've been living in this traditional MIPS program since that first performance year of 2017. And over the last few years in 2021, 22, CMS started introducing us to this concept of a MIPS Value Pathway that the program will eventually transition into. I do want to point out that CMS has still not picked a specific sunset date for traditional MIPS. Every indication in this final rule, as with previous ones, do indicate that it is coming. Right now, I think what we're hearing and what we're seeing from this is likely around 28, 29. But I do want to make sure that we do put a big asterisk by that. CMS has not finalized an end date for the program. So it could potentially, traditional MIPS could be an option beyond that point. As soon as we know, we will let you know when we have to move into these other strategic pathways. So after that MVP pathway, you do move into the world of ACOs. And so you have the APM performance pathway. This is primarily going to be for those types of ACOs that are what's considered a MIPS APM. That's a specially deemed um, uh, ACO program that meets CMS requirements to be considered a MIPS APM. You have a special APP track that you participate in with a measure set that the team will talk to you a little bit more about some of those finalized changes that CMS is putting forward that impacts the APP. And then finally, the last part in this track of the program are for advanced APMs. So these are those special types of alternative payment models that have typically a higher level of upside and downside risk. They are going to be a lot of those full capitation models where you're assuming that full risk and full reward for the care that you provide. A lot of times they'll have prospective payments for your beneficiaries, things like that. If you are part of that advanced APM model, you are going to be MIPS exempt. So you do not have to report through the quality payment program as long as you meet certain criteria and become a qualifying participant in that advanced alternative payment model. If perhaps you don't meet certain criteria, you would then still be obligated to report in the quality payment program, and typically you would report through the APP, that MIPS APM pathway. Now, just to talk a little bit about some of our eligibility, category weights, and payment adjustments. The good news is CMS has not made any changes to scoring of the categories, reweighting policies, anything like that. So quality and cost are remaining at 30% as mandated by federal legislation with the creation of the MACRA program. And then PI has been maintained at 25 with improvement activities still at 15. CMS has not made any changes to the eligibility to be able to be obligated to report for the program. So we're still maintaining that low volume threshold of being able to have a $90,000 in Part B billing during the performance year, as well as 200 Medicare beneficiaries and 200 covered professional services. CMS is allowing that automatic PI reweighting to remain for those special status designations, such as HIPSA, as well as small practice. That PI reweighting has remained in place, and some other flexibility for like ambulatory surgical centers. CMS has not extended the program to any other new eligible clinician types, so we haven't seen any changes in that regard. CMS has continued to finalize the threshold to avoid penalty, right? So in order to stay out of the penalty box and to not receive a negative payment adjustment, you have to earn 75 points across all 4 of the performance categories. And so that'll get you a neutral payment. Anything above 75.01 all the way to 100 points, you could be eligible for a possible positive payment adjustment, right? And so that can go all the way up to 9%. We have yet to see those really high positive payment adjustments with this program, but we do see on the inverse side of if you aren't fully participating in the program, there can be negative payment adjustments all the way to that full negative 9%. So that is something to consider. CMS, just to let you all know too, is CMS has, they look at that payment adjustment threshold and they look at it based on the average of previous performance years. That's built into that, actually the federal legislation built around the MACRA program that has created the quality payment program. And so they look at, and every 3 years they reweigh what is going to be that threshold. for participation. And so with this 2025 rule, that locked in the next 3 years. So we're looking at 25, 26, and 27 that we're going to be around that 75-point threshold that has been finalized. Now, I want to talk with you a little bit about data submission. So CMS put forward some clarifying language around data submissions for the different submission categories for traditional MIPS and for MVPs. Because remember, anything we do for traditional MIPS, it typically grandfathers into MIPS Value Pathways. So because of some of the feedback that CMS has received from clinicians and practices regarding some of the ambiguity with reweightings and EUC policies, CMS really wanted to clarify what counts as an intentional submission. So with this final rule, they really kind of cleaned up some of the language. So that's what we're seeing here on this slide, but I think it's also important for us to just talk through it a little bit to get a better understanding of what that means. So the changes that CMS has put into place, these are all retroactive for 2024, meaning these are going to actually go into effect for after we submit our data for this current performance year here in the late winter, spring. And so for quality, CMS is defining an intentional quality submission as that numerator and denominator submission for at least one MIPS clinical quality measure. Okay, so if you just submit one, and it has a numerator and denominator, CMS is going to look at that as an intentional submission. Something else to point out that when we were digging through the nearly 3,100 pages of this particular piece of regulation, so that you guys don't have to, one of the things that really stuck out to me is for our folks who are in small practices who submit Part B claims. So CMS is saying that a single submission of a QDC or a quality data code for a single Part B claim is going to be counted as a qualifying data submission. So I think that's incredibly important for our small practices who do have maybe some measures that they are submitting pieces of data to CMS with those quality data codes that are associated with them. CMS will look at that and count that as a submission. So if you do have an EUC, by doing those submissions and having those codes attached, that could actually knock you out of your EUC flexibility, your extreme and uncontrollable circumstances flexibility. Now, for improvement activities, CMS has just simply defined that submitting a yes response to at least one activity is how they are going to identify that you have intentionally submitted for that category. That's not going to impact our MIPS APMs or our medical home practices who are part of the APP track. You have some built-in special flexibility with that particular program that you automatically get credit for improvement activities right now. Now, for promoting interoperability, CMS just further defined the criteria. You need to make sure that you have performance data that's been submitted, including any type of attestation around any exclusions that you're claiming. Also, they want to make sure that you have completed all attestation statements. Again, that's nothing new. That's always been a hard stop. You also have to have your CERT, your EHR CERT identification number. That's a part of that. Again, that's been a recent requirement they've added. And then they also want to make sure that that start and end date for the performance period has been entered in and is a part of your submission. So taking it another step further, because with all of our categories, there's opportunities for multiple submissions. CMS took a deeper dive into this and really wanted to kind of tease this out because it's been a little frustrating for practices. So to clarify, if you are submitting for the quality and promoting interoperability performance categories, CMS looks at it from two different levels. They are going to look at it from those that are submitting from multiple outside organizations. So say you're working with an EHR who can generate a QRDA3 file and submit it on your behalf. You're also working with maybe one or two registries who generates a file or does a direct upload through an API for your quality or interoperability categories. What CMS has decided is that they are going to score each and every submission from any of those outside entities, and they will assign the highest score possible for those measures. Now, it's a slightly different story if you're submitting within the same organization. Okay, so say you are a security official and you also have another security official, or you have somebody else on the staff that has a staff user role as a part of the QPP portal. If you do a submission on Monday and then your other counterpart does a quality submission on Tuesday, CMS is only going to look at that submission that happened on Tuesday. And so if there's a data discrepancy, if your performance was better on that Monday submission and maybe a measure was left off on that Tuesday submission, that's what they're going to go with, is that final submission. So I think the big takeaway here is knowing what hands are in that bucket to be able to submit data from within the same organization. You want to make sure the most recent submission is what you want to submit for that category. Because the way the system is built, it automatically writes over it. And then finally, I just want to talk to you about promoting interoperability. CMS has made this one really simple. Regardless of who submits the data, whether it's internal within your organization or from an outside entity, CMS is going to score each and every individual data submission and then assign the highest score from those. So seems like, a little bit of kind of picking hairs and looking at that detail, but it is something that's important to keep in mind. Who is submitting your data and what that's going to look like. With that, I am going to turn it over to Jared to talk a little bit about the different performance categories.
Thank you, Jessica, and good afternoon, everyone. Thanks for joining us. So I'm going to kick us off here with some updates to the quality category. First, there were no changes in the category weight for any of the three performance tracks. Data completeness requirement has been maintained at 75% through calendar year 2028. This is a good sign. We've seen some proposals in the past that look like this would increase, but I'm really glad it stayed and it's holding through 2028. Now, the bulk of the changes in the quality category came from measure updates. CMS has made substantial modifications to 66 measures. These have affected some of our more common measures that we've seen, such as diabetes A1C control and documentation of current meds in the medical record that most of our clients typically report. There were also 7 new quality measures added, but unfortunately, all of these were MIPS CQMs, and we didn't get any new ECQM measures. There were also 10 measures removed that will take place January 1, 2025. CMS has removed the 7-point measure cap for specialty sets with limited measure choices. So for those of you that do report through those measure sets, this is something that you definitely want to be aware of. And then as I think kind of about key impacts with these changes, I really think that eligible clinicians are going to have to rely more and more on QCDRs and qualified registries to get measures. We've seen through this year that it's become really challenging with ECQMs. There's not a whole lot that have benchmarks, so it really makes them unusable for attestation. And CMS isn't putting a focus on adding any more in. This is going to push clinicians to have to get metrics elsewhere, and that can be a really pricey endeavor, especially for some of our smaller practices. I also want to highlight that patient-reported outcome measures are becoming more popular. There's been a handful of these measures pop up through the past couple rulemaking cycles. We also got 2 more out of this rule. And I think as remote patient monitoring continues to grow, I think these measures are going to start playing more and more of a role in your MIPS reporting. Moving on, we will talk about the PI category. Good news here is that there are no major changes that came out of this final rule. All of your objectives, your measures, and scoring all remained the same. Some things to keep in mind though, safer guides will be getting updated in 2025, and those new guides will be required calendar year 2026. Outside of this rule, but it's still important to note with the ONC certification, decision support interventions will be required starting January 1, 2025. If you've tuned into our webinars before, we've talked about PI quite a bit. And if you work with Ms. Robin, then you've definitely heard this before. But live by 2025 is here, folks, for public health reporting. What I mean by this is if you have attested to that option one, the pre-production and validation phase before, usually meaning that you have an addendum in place with KHI, those practices will need to move to option two, the validated data production phase. You can only be in this option one phase for one performance period now, which is 1 year. This is a really good time to go ahead and reach out to your KHI representative and see what you need to do to be live for 2025. Looking at the improvement activities category, we did have some major changes here, but don't sweat. These changes should help alleviate some of that burden and stress when it comes to MIPS reporting. Starting in program year 2025, activity weights will be removed. So there will be no medium or highly weighted activities anymore. Along with this, CMS has lowered the number of activities required to report to receive full credit. For those that participate in traditional MIPS and don't have any of those special statuses, this would mean that you need to attest to only 2 activities. If you do have those special statuses or participate as an MVP, you will only need to complete 1 activity. There were 2 new measures added to the improvement activities category, increasing lung cancer screening uptake and Save a Million Hearts. Modified 1 activity, and CMS removed 4 activities from the inventory. Now, the removal of 24/7 access to MIPS eligible clinicians is a pretty big removal. This is a very common measure used not only here in Kentucky, but nationally. But CMS has said that in this rulemaking that this measure has really become an industry standard and not so much contributing to improvement of care. So that is why they removed it. CMS has also gone on to codify 7 removal criteria for how they're going to go about removing measures from the inventory, just to create a little bit more transparency. But thinking about this in the future of the category, the writing's kind of on the wall that CMS is going to be revamping the activity inventory pretty significantly in the coming years. And I would anticipate more and more measures being removed as CMS tries to keep the inventory robust and relevant. And lastly, everybody's favorite category, the cost category. I'm going to go through this slide fairly quickly because I'll expand on a few of them in the next few slides. We did get 6 new episode-based measures added and none removed in this rule. There is a new benchmarking methodology that aligns with the quality benchmarking that will take place this attestation in program year 2024. CMS has also finalized clear guidelines of how they will remove cost measures as they had not had any previously. Overall, we should expect to see more favorable scoring come out of the cost category with some of these updates, especially to the benchmarks. So here are those 6 new measures that we got. Each of these will have a case minimum of 20. With the addition of these 6 new measures, that brings inventory to a total of 35 cost measures that eligible clinicians could be scored on. If you feel that these measures may be applicable to the services that you offer, I would recommend taking a look at those measure specification sheets when they're released to review for those billing codes attached so you can plan ahead for 2025. So as I mentioned, the scoring methodology with the benchmarks has changed, and we wanted to give you a brief overview of what this looks like. So CMS is still going to use performance period benchmarking, but this methodology will align more closely to what the quality benchmarking methodology looks like. So instead of using flat benchmarks like they had in past years or on the left side of your screen, they're going to look at the median performance. Should see some more favorable scoring for clinicians that are lower than that national median. This is going to be based on the standard deviation. So how far away are you from that median? So you can think of this as a bell curve with that national median right there in the middle. And the further you get away, the worse or better your score will be. Switching gears here to talk about MVPs. Jessica kind of touched on it at the beginning of the presentation, but the big news here is that traditional MIPS could be sunsetting in 2029. Nothing's been confirmed yet, but I just want to make sure that this is on your radar. They are looking for feedback when they release notice of proposed rulemakings. So if you feel strongly about this, let them know. They are specifically seeking any challenges with data, your vendor support, is your vendor ready for MVPs, any subgroup issues that you've ran into that would delay the sunset of traditional MIPS in 2029. Continuing on with MVPs, CMS has made modifications to all 16 MVPs that were previously finalized. There were some changes to registration and scoring of population health measures as well. Previously, you would choose the population health measure you wanted to be scored on, but starting in 2025, you will be scored on whichever population health measure you scored the highest on, and that is included within your selected MVP. If those case minimums aren't met, then or there are no benchmarks, then the population health measure would still be excluded like it has been in past years. Cost measure scoring has been codified as well to align with traditional MIPS and the cost changes that were noticed there. And lastly, I wanted to share the full inventory of MVPs for use for program year 2025. We did get 6 new MVPs added through this rulemaking, giving organizations a total of 21 to choose from. CMS feels that now 80% of the specialties are covered by an MVP. I think it's important to put some focus on where the program is heading, and MVPs are really that next step in CMS's goal to that full capitation model that they're hoping to reach. As we see the growth of MVPs and cost measures, CMS is really working to align performance and to get specialties involved in these pathways. I would anticipate CMS putting pressure on vendors to support MVPs as we inch closer to 2029 and the potential sunset of traditional MIPS. I'm now going to hand it off to Miss Robin Kernel and give you all a break from listening to me. So take it away, Robin.
Thanks, Jared. So thanks for joining us today. I'm going to wrap us up with the last few slides, and we're going to talk about finalized changes to alternative payment models, some specifics for some Medicare Shared Savings plans, and then wrap it up with the some things outside of the physician fee schedule QPP update, and then some of our top impacts that we feel like for impacting clients this year. So let's start here with alternative advanced payment models and the APP pathway. So many acronyms, we just can't get enough. So over the course of the quality payment program, we've witnessed several changes in the lump sum payments for qualifying participants in an advanced payment model. If you remember, they started out at 5%, and then originally they were planning to drop a certain percentage and be ending within the 5th year of the program, but due to some late action by Congress in the last couple of years, there's been some extensions. This year for 2024, the lump sum payments will end unless there is again some last minute action. Right now, we don't anticipate any last hour adjustments, but we still got a few days left in December. There were some retroactive changes in this final rule for the 2025 calendar year, though. We will still keep this 1.88% partial lump sum, oh my word, lump sum payment for this year. In addition to qualifying participants will also get a 0.75 conversion factor on their payment rates. So they're actually getting two things for 2024. And then going forward, it will just be that conversion factor added into their payment rates going forward. PI category reporting, there was no changes, just like there hasn't been in anything else related to traditional MIPS or MVPs. PI category is going to be required regardless of what program you're testing to. So whether it's traditional MIPS or an ACO. Participants must submit PI. You need to work with your ACO and determine whether you're submitting it through them or if it's through the portal. You can always submit your own PI through your portal. There is a complex patient adjustment retained for alternative advanced payment models. CMS also had proposed to make changes to their attribution eligible beneficiary assignment, but elected in this final rule not to move forward with that. And so they elected to continue with utilizing E&M codes for beneficiary assignment determination versus their other proposal of using some claims data. When we look at qualifying participant threshold determinations, this again has something that was delayed several times, but for 2025, in order to be deemed a full qualifying participant in an ACO, 75% of the payments, beneficiary payments, must come through your ACO, and you have to have at least 50% of your patients enrolled in the ACO. There are partial QP finalized thresholds as well, and that's at 50% and 35% for your patient count. If you remember at the last hour for 2024, we also had a little bit of a reversal back, and for this year only, full QP status is at 50% of your payments through the ACO and 35% of your patients enrolled. Going forward, qualifying participant determinations will only be at the individual clinician level, no longer at the APM entity. And that's important for later in our discussion. So moving forward with our alphabet soup, the APM performance pathway, or the APP, has now been modified to APP Plus. And if you are deemed not, or if you are deemed part of a qualifying participant or a partial QP, you have the option to not only submit through your ACO, but you can also submit through this APP pathway. If you're part of an ACO and not deemed a qualifying participant, you need to remember that you must report through traditional MIPS. So don't ever forget that you have to constantly check your eligibility status. So CMS released this APP pathway in 2023. So you had the option to submit your quality category data using web-based measures or ECQMs. For Medicare Shared Savings Programs, this 2024 was the last year that you could submit via web-based measures. CMS is pushing APM groups to submit using ECQMs or Medicare CQMs. As with all things CMS, they've updated this QPP or APP measure set and renamed it APP Plus. And for 2025, they've added an additional 2 measures. And CMS has told us in this final rule that they will continue to add measures to reach a total of 11 required, and they have given us the measures to expect and the timeline for implementation. Their proposal to give us this timeline was to allow for EHRs and registries and APMs to be able to plan ahead and prepare for measure collection. So for 2024, you have this core measure set. For next year, they're adding breast cancer screening and colorectal. 26 will be substance abuse. And they'll skip a year and give us to 2028 to start reporting social determinants of health and adult immunization status. And then our last slide talking about MIPS APMs and Medicare Shared Savings Plan updates. To be successful and get quality performance standard to get your max shared savings, beginning on the left side, quality performance must be a priority. Documentation is necessary to meet those quality measures. Using that APP measure or APP plus measure set, making sure that you have patients who are enrolled who meet the dual eligibility requirements. That helps with your complex scoring, and also your health equity measures. And understand that quality scores are aggregated amongst all providers in the APM. And just as a freebie here, CMS has a goal of all traditional Medicare beneficiaries to be enrolled in some type of alternative payment arrangement by 2030. And that'll be here before we know it. Because of the changes they're making, CMS has sent out in this final rule requests for information and feedback from you all regarding future updates for the Medicare Shared Savings Program and other alternative payment models. If you remember, in the 2024 final rule, CMS released advanced investment payments. We call those AIPs for Medicare Shared Savings Programs to encourage the startup and development of ACOs. Those payments do have to be paid back, but are done so over time out of the shared savings. CMS is now offering prepaid savings for ACOs who are current and active, but they have to be in track C through E. So if you remember, Medicare Shared Savings Plans have multiple tracks that range from 0 risk to high risk up to 8%, and they are split by A, B, C, D, E. So these prepaid payments are paid back as well through future savings as the ACO moves forward, but these are meant to be used for staffing or infrastructure, things that would be a direct service to beneficiaries. Also new is ACOs must maintain that minimum requirement of 5,000 enrolled beneficiaries at the time of the renewal period. So we recommend over recruitment. And then as finally, with all things from CMS, health equity and social determinants of health are being incorporated in all programs. APMs are no different. And then also mentioned, but not on this slide, is in this final rule, and it was in hospital IPPS rule, a new alternative payment model called TEAM. It's transforming episode accountability model. It'll launch in January of 2026. It mainly impacts acute care hospitals, but you could have clinicians enrolled in it, and that may help you with, advanced alternative payment models for your providers too. So don't assume that that one is just a hospital only base. That could affect some of your clinicians. So things to know outside of the final rule. These are some things that we try to keep our finger on for folks because we know that it impacts some of you. So beginning with telehealth, of course, we know that this has been around for a while, but it became a big push with COVID. We had lots of waivers offered. One of which that was pretty significant is the patient's originating site. So I want you to keep in mind that everything that we're talking about today is strictly applies to Medicare beneficiaries. Telehealth provided to patients with other insurance carriers could have different policies, particularly state Medicaid and private insurers. And then we have to remember as well that telehealth policy is not singularly controlled by CMS. Many of the waivers were put in place during executive order and by Congress, federal legislation. And as such, if Congress does not act sooner than later towards the end of this year, then many of those things will be retroactive to what they were prior to the public health emergency. So a couple of things that's when on CMS is attempting to mitigate any potential impact should Congress not act to extend the waiver deadline. CMS can pass some actions, but for the waivers and some specifics, Congress has control of telehealth through this federal statute. And as if it's not confusing enough, Congress has more control than CMS when it comes to patient location. Currently, rural health clinics and FQHCs can be originating sites for patients, and that will remain should Congress does not act. What we hope to see before the end of the year is that the patient's home can be the originating site for Medicare beneficiaries. Other things done with this final rule is CMS, updated the definition of interactive communication to allow for audio only. They introduced 2 new G codes to be added to the permanent list. If you remember, we have a permanent and a provisional list out right now. And again, those things that are on that provisional may not get added to the permanent list before the end of the year. So what's at risk if Congress doesn't act? Patient access is going to be limited. Medicaid and commercial insurances will pay for telehealth services according to their contract, but for medical services, and I say that because behavioral health has a little difference, but for medical services for traditional Medicare patients, it will be limited to only being seen at a rural or a HIPSA site as the originating site, no longer the patient's home. Congress can come in with the late hour update, or we could see an administrative order that could give us some extensions to allow Congress more time, but none of that is known at this time. But just to reiterate, Kentucky Medicaid will not change. They have excellent payer rules when it comes to telehealth services. And then your commercial payers, they're going to follow the contract arrangements. So colorectal cancer screening, there's always an update about CRC in this rule. They've just made a few minor changes here. They are no longer going to cover barium enemas for screening, and they are adding some coverage for colonography procedures for screening. That gives us another test, and then including a biomarker test along with a non-invasive stool-based to call it a complete CRC screening. And then Medicare Diabetes Prevention Program. At the REC, we do a lot of work around diabetes care, self-management. We help with a lot of grants and stuff that support patients in self-management programs and education. So we do keep an eye on what's changing here. So as just an update, they've added some new terminology. They are allowing self-reported weight collection. That's new. We haven't been able to do that for any ECQMs before. And so now they're at least allowing it for this program. And then they're removing some payments and some G codes there too. So they're adding a new modifier. So if you have a makeup session for some of the education that you're providing, you'll have to modify your claim with a modifier 79. So that wraps up the majority of our presentation. We're going to talk about some finalized things, our overall highlights that we feel are pretty significant for this year. I'm going to bring both my colleagues back into the discussion, and I think we're going to start with Jessica today and just let her talk about some things on this list.
Thank you, Robin. First, I want to preface this by saying this list, even though it's numbered, is not in necessarily order of priority or importance. But just wanted to put that out there. We think all of these are important and definitely issues that we want to make sure out of all of this word salad that we've given you today, these are some of your main takeaways. So the first thing I want to just bring up, and Jared talked about this, is that CMS hasn't proposed any new additional ECQMs, or finalized them. We are seeing more and more MIPS CQMs that would then require a registry. So that is definitely something to continue to explore, especially as we further that transition to MIPS Value Pathways, what is quality submission going to look like for you and your organization in future performance years? Data completeness, I think that's great that we have that benchmark through 2020 or to 2028 that we're going to maintain at 75%. But just know that that is on the radar when you are especially it's important whenever you are reporting your claims based measures as well as your MIPS CQMs. That's really when data completeness really does matter. CMS assumes that with your EHR, you are submitting 100% data completeness per every measure. One other thing I want to call out again is the removal of 24/7 access. This particular improvement activity has been utilized by a lot of our practices. A lot of you folks on the call have used this one in the past and maybe are even using it this year. It is still available for 2024, but it has finalized. It is being removed for 2025. CMS feels that this measure has been exhausted and that these systems are already in place to support this. I think there's a little bit of a disconnect because I think all of us know, boots on the ground, that 24/7 access is difficult to be able to get patients necessarily worked in same day, next day. There's still a lot of work that we have to do in that regard. So I think the activities are still important, even though you might not be able to claim that specifically as an improvement activity. So basically what that translates to is if you've been depending on this to meet one of your improvement activity requirements, it's an important time to start digging through the current improvement activities for 2025. Talk with your REC advisor to get a plan in place for any of these new improvement activities. We are always happy to sit down with you, pull a list of activities and go through some of the documentation requirements to see which is going to be the best fit for your practice. Because remember, improvement activities, it's an easy category to be able to meet the mark. You just have to have the documentation. And we just want you to do something that is sort of low-hanging fruit, something that you're already doing that you can take and incorporate into this particular category. Additionally, want to talk with you about the SAFER guides. Jared mentioned that the SAFER guides are going into effect in 2026. We might see those changes come through sometime during 2025. CMS has indicated that if you would like to go ahead in 25 and move to that new SAFER guide, if it's available, you're welcome to do so. But for 2025, you can use the current high priority practices SAFER guide, or if it comes out in time, you can upgrade, so to speak, to that one that is coming out. 2026, we do foresee that they will make that one be the required guide that you'd have to do is that version. And then finally, the removal of improvement activity weights and reducing the number of required or available activities. I think there's a couple things going on with this one, particularly. Removing the weights and reducing the number of activities, I think is a great step for the program. That's a little bit less documentation, a little bit less burden on those practices. For you all to have to be able to keep up the documentation for, especially if you're reporting at that larger group level. Again, the narrowing of improvement activities, that does make us have to focus in and maybe dig a little bit deeper to pick those activities. But again, we are here to help guide and support you through that process. And with that, I will hand it over to Jared to talk about the rest of those impacts.
Thanks, Jess. So I'll run through our last 5 here, starting with the APP measure set. With the growing of the APP measure set, it was nice to see that CMS has given us that timeline and the measures that they plan to implement. But this is going to require those of you that perform through the APP plus set that, the number of measures are going to grow that you have to attest to. The next one, it's always nice to see that performance threshold maintain at 75 points. I think with some of the other changes, CMS is recognizing that the program is just naturally getting harder. And so it's already going to be harder to reach that threshold of 75. Looking at topped-out measure benchmarks for specialty measure sets, the removal of that 7-point cap is going to affect some of those clinicians that participate through the specialty measure sets, and hopefully it is in a positive way. It's going to be interesting to see how that plays out in 2025. We got 6 new MVPs. I think this is going to really help encourage some of those specialists to start performing through MIPS Value Pathways. And then lastly, the new cost measures, we did get 6 of them, and the updating benchmarking really should have a positive impact that does start with this attestation coming up in just a few months. And hopefully we see your cost scores go up. That is all I've got. I'll turn it back over to Ms. Colonel.
So we want to talk about some action items, what you might need to prepare for 2025. I feel like that we need a recording that says live in 2025 for all of our public health registries. You know, traditional MIPS or promoting interoperability category requires at least 2 for you all, immunization registry or ECR, electronic case reporting. You may be eligible for exclusions. You need to make that decision and have policies in place on how you handle that. If you do meet the requirements and have to attest to being an active engagement, you need to start on that sooner and later. Keep in mind that we have, 180-day reporting period. The last day to start that is July 5th. And so you want to be active within 60 days of the start of the reporting period. And you don't want to wait. This sometimes is a drawn out process and you want to get started as soon as you can. EHR vendors are going to have to be certified as a registry to be able to report your data or to attest on your behalf. And we have a couple vendors who do that for our clients. And many of them are on the game and getting that completed, but just keep that in mind that it may be that you have to submit your own data for 2025. And then we want to encourage you to review that proven activity list. We've saw some good flexibilities there. They reduced the number required for attestation. You don't have to worry about if it's high weighted or medium weighted, but just make sure that you have the data to support the activity to participate in, and you meet that 50% clinician requirement that are participating in that activity, and dates. You need your start and stop dates. If it's a full year, not if it's 90 days, whatever it is, you need to have dates. And then finally, renew those or review those new cost measures. CMS is intending to make sure that each specialty type, primary care, all have a cost measure that could be applicable to your practice. So review those and see if they could be applicable, could apply to your practice. So with that being said, if you've got any questions, we've got a few minutes left in this hour. Feel free to put them in the chat. Otherwise, reach out to your advisor. This was a client-only webinar today, and we will repeat it later in 2025, but a much more abbreviated version and open it up to the public. So if you have any questions, you can put those in the chat if you have that option at the bottom of your screen, or email us at one of the options here, or again, reach out to your personal advisor. I'm not seeing anything pop up. Do you all have anything on your side that you see, Jessica or Jared?
I am not seeing anything from my view.
I don't as well.
All right. Well, folks, we'll give you 5 minutes back in your day. We appreciate you joining us. We will be sending out slides in the recording as soon as it's available. Thank you.
Thank you.